Hi friends, welcome to my blog ECG Basics. Today we will be discussing about the genesis of the waveforms, QRS nomenclature, leads and electrodes, and leads misplacement, and the findings of the ECG if leads are misplaced. We have already discussed this slide in the previous lecture, that whenever a positive charge comes towards a lead, that the ECG changes shown in that leads are positive deflection, as it is depicted here. And whenever a positive charge moves away from a lead, we get a negative deflection. If any lead is placed perpendicular to the vector, we get the initial positive wave, and then we have negative deflection. We will discuss about the normal PQRS complexes. This is a P wave. This is due to atrial depolarization, and these are the QRS complexes. This is the Q wave, this is R wave, this is S wave, and this is due to ventricular depolarization. T waves are due to ventricular repolarization, and U waves are due to papillary depolarizations. P wave is the first positive deflection in the ECG. It represents the atrial depolarization. Normal duration of the P wave is less than 0.12 second, or we can say less than 120 milliseconds, or it is less than 3 small scale. These are usually monophasic in lead 2, and these are P waves are maybe biphasic in V1, V2 and V3. They are upright in lead 1 and lead 2, and they are inverted in AVR. Amplitude of the P wave, this is the amplitude. It is usually less than 2.5 in limb leads and less than 1.5 in precordial leads. Means in limb leads their size will be less than 2.5, means hardly less than 3 small squares in limb leads, and it will be less than 1.5 in precordial leads. The first 1/3 of the P wave, it is represented by the right atrium. Last 1/3 is represented by the left atrium, and in between this middle 1/3, it is represented by both the atrias. If there is any abnormality with the right atrium, we will get the findings in the initial 1/3 or the initial half, and if we have any abnormality in the left atrium, we will have abnormality of the P wave in the later 1/3 or the later half of the P wave. Q wave is the first negative deflection in the QRS complex preceding the R wave, and represent the normal left to right depolarization of the interventricular septum. As we have seen that if this is the heart and this is the interventricular septum, the initial vector goes like in this direction, that is from left to right. Okay, the Q wave, they represent the left to right depolarization of the interventricular septum. Means septum is depolarized from left to right side. Small septal Q waves are seen in the left sided leads, that is lead 1, AVL, V5, V6. So we will get the Q waves, small Q waves in lead 1, AVL, V5 and V6. When do we say that ECG is showing pathological Q wave? Pathological Q wave, we will say when the width of the Q wave, that is the width of the Q wave, will be more than 40 milliseconds, or more than 1 mm, or we can say more than 1 small square wide. If they are more than 1 small square wide, more than 1 mm or more than 40 milliseconds, we call them as a pathological Q wave. Or if they are more than 2 millimeter deep, or if more than 25% of the depth of the QRS complex, or R wave. If this Q wave, if it is more than 1/4, 25% of the QRS complex, we call it as pathological Q wave, and it is seen in V1 and V3, V1, V2 and V3. Presence of Q waves, pathological Q wave indicates the current MI or prior myocardial infarction. The absent Q waves, if present, if they are absent Q waves in V5 and V6, as we said, ki small Q waves are seen in the left sided leads, that's lead 1, AVL, V5 and V6. If they are absent in V5 and V6, we should think of left bundle branch block. So in this picture we can see that width of the this Q wave is more than 0.04 second or 40 milliseconds, or more than one small square, we call it as a pathological Q wave. Or if this is this depth of the Q wave, if it is more than one fourth of the R wave, means if we divide into 4 parts the R wave, if it is more than 1/4 of the R wave, depth is more than 1/4 of the R wave, then we call it as a pathological Q wave. And this pathological Q wave is also seen as a cavity potential. Cavity potential is basically when there is left ventricular hypertrophy and the patient has volume overload, means the left ventricular cavity is filled with more blood, volume overload, we also see then these pathological Q waves. So pathological Q waves will be seen in recent MI, prior history of prior MI, and the patients of left ventricular failure with volume overload states. Otherwise, pathological Q waves are not seen in normal ECGs. Only a small Q waves are seen in lateral leads, that is lead 1, AVL, V5 and V6. Coming to the QRS nomenclature, the first negative deflection in QRS complex is the Q wave, or we can say any negative deflection which comes before R wave in QRS complex is the Q wave. And any positive deflection or the first positive deflection in the QRS complex is the R wave, or we can say the first positive deflection after a negative deflection is the R wave. And any negative deflection after the R wave, we call it as S wave, or we can say second negative deflection in the QRS complex is the S wave. So S wave is negative deflection after the R wave. In this picture we don't see any R wave, we call it as QS complexes. There are instances where we see first positive deflection, that is R wave, thereafter we get negative deflection, that is S wave, and again we get another positive deflection in the QRS complex, we call it as a R dash or R prime, and this we write it as a RSR dash pattern or RSR prime pattern, and it is usually seen in the bundle branch blocks. I will discuss about the bundle branch blocks in my subsequent lectures. Coming to the QRS complexes, for just better understanding, we will just consider the leads V1 and V5 or V6. It will give us a more detail about the QRS complexes. As we know that the first deflection after when the impulse comes in the septum, it goes in this direction, that is from left to right interventricular septal depolarization is there. Since it is going like this, we will get a positive deflection in the V1. That positive deflection will be a small R wave, and in the its counterpart, that is in lead V5 or V6, we will get a small negative deflection, that is the Q wave. Next we see the position of the vector, the impulse go like this. Since mass of the left ventricle has very large quantity of mass, or we can say the free wall of the left ventricle has more mass as compared to the interventricular septum of the right ventricle. So this is moving towards the impulse is moving towards the V5 or V6, we will get a very strong, because of large mass, we will get a very strong positive deflection in V5 or V6. That will be the R wave, and it's in contrary, we will get a very large negative deflection in the V1 or V2, and that will be the S wave. I hope you understand. And thereafter we see that after depolarizing the most part of the ventricle, the impulse go towards the base of the heart, towards the base of the heart, and that will show small negative deflection. It will show small negative deflection in the V5 or V6, that will be S wave. As the impulse is moving away from V5 V6, we get small negative deflection in the S wave. Okay, I hope it's clear. So what we see here, that if we just see the lead V1 to V6, so here we notice that as we move from V1 to V6, the R wave, amplitude of the R wave goes on increasing, and the amplitude of the S wave goes on decreasing. This R wave, amplitude of the R wave increases from V1 to V6. We call it as R wave progression. R wave progression, and it is normal. It is a normal ECG findings. Similarly, we can say as we progress from V1 to V6 in precordial leads, the amplitude of the S wave, it decreases, and this is also a normal finding in the normal ECG. If we don't find R wave progression in precordial lead in ECG, we call it as a poor R wave progression, and it at times it can be abnormal, though it can be seen in some normal ECGs also. But if this R wave progression is not there, we should think of the cardiac abnormalities, which I am going to discuss in the next slide. R wave progression, poor R wave progression we usually say when the amplitude of the R wave in lead V3 is less than 3 mm. Here we can see that this is the normal ECG, R wave is progressing. This is also a normal, but here we see that amplitude of the R wave in lead V3 is less than 3 mm, or we can say it is also late R wave progression. This is a normal R wave progression. This is the early R wave progression, but in the later leads like V6, the R wave size of the R wave, the amplitude of the R wave decreases as compared to V5. These are the normal findings. We can see early R wave progression, we can see late R wave progression, but if the amplitude of the R wave in lead V3 is less than 3 mm, we call it as a poor R wave progression. And poor R wave progression is usually seen in the patients who have the history of prior anteroseptal MI, left ventricular hypertrophy, Wolff-Parkinson-White syndrome, left bundle branch block, dextrocardia, or if the leads are misplaced, or the patient have ECG findings of tachycardia. It may be a normal variant, but before declaring it as an abnormal finding, we have to rule out all these conditions, that is prior anteroseptal MI, left ventricular hypertrophy, Wolff-Parkinson-White syndrome, left bundle branch block, dextrocardia. If they are absent, then only we can say that this R wave progression, poor R wave progression, is a normal variant. I will once again repeat that R wave progression, we usually say if the amplitude of the R wave increases from V1 to V6, but we to label it as a poor R wave progression, the R wave height should be less than 3 mm in V3. And there are instances where we get early R wave progression, that is the R wave size increases, but in the later leads its sizes decreases as compared to the previous leads. And we have seen the lateral R wave progression also, that the size of the R wave usually doesn't increase in initial leads, but in later leads it starts increasing. But we will say these are the variants of the R wave, poor R wave progression, and this is the normal. Poor R wave progression may be early R wave progression or late R wave progression, and we label the poor R wave progression only when the height of the R wave or the amplitude of the R wave in V3 is less than 3 mm, and it is seen in history of prior anteroseptal myocardial infarction, left ventricular hypertrophy, dextrocardia, Wolff-Parkinson-White syndrome, left bundle branch block, and it can be seen in patients who have ECG findings suggestive of tachycardia, and it can be normal variant in some person also. But to label it as a normal findings, we have to first exclude all these causes. QRS complexes can be narrow complex QRS, or we can say broad complex QRS. Normal QRS width is usually 60 to 100 mm, or we can say less than 3 small squares. If the QRS complex width is less than 100 milliseconds, they are usually of supraventricular origin. Supraventricular origin means they are originating from either from the atria or the AV nodes, or we can classify into broad complex QRS if the width is more than 100 millisecond. They are usually ventricular or aberrant conduction of the supraventricular complexes, may be due to bundle branch block, hyperkalemia, or sodium channel blockade. These complexes, narrow complexes QRS and broad complexes QRS, they usually are abnormal arrhythmias, or we can say these are abnormal ECG findings. They are arrhythmias, and this I will discuss in my subsequent lectures. Coming to the leads and electrodes, the leads which we place on a patient, they are usually divided into limb leads and precordial leads. Limb leads are usually placed on limbs of the patients. Precordial leads are placed on the precordium, that is over the chest. Limb leads are lead 1, lead 2, lead 3, or augmented leads, that is AVF, AVR, AVL. And precordial leads are V1 to V6, and rarely, if we suspect a patient has right ventricular myocardial infarction, we can use the V4 or V5R leads also. Here we can see the lead 1 is represented by when the positive electrode is present on the placed on the left arm, and negative electrode is placed on the right arm, and it is represented by the lead 1, and the direction of the vector is in this direction, that is towards the this left arm. This is lead 1. The lead 2 will have this direction, that is there will be negative electrode placed in the left arm, positive electrode placed on the left leg, and it is a lead 2, direction of the lead 2 axis. And similarly we have lead 3, the positive electrode is placed on the left leg, negative electrode is placed on the left arm, and this is the direction of the lead 3. So this is making an equilateral triangle. This is called Interven's equilateral triangle. It is the name after the scientist who discovered this role of this Interven's triangle in the interpretation of the ECG. The Interven's triangle, or we can say Interven's law, says that lead 1 plus lead 3 minus lead 2 is equal to 0, or we can say lead 1 plus lead 3 is equal to lead 2. The lead which is placed on the right leg is usually a neutral electrode, and it has no deflection. Coming to the augmented leads, we categorize them AVL, AVR, and A. Augmented leads are usually used to increase or enhance the action potential across the limb leads. here the electrical activity gets augmented, enhanced. For example, we use this left arm and left leg as a single lead and right arm as a another lead, and it increases the recorded action potential. This is for lead AVR, and for lead AVL we use left arm as a single lead and we use the right arm and left leg as a one lead, and to enhance the action potential across the AVL. Similarly for AVF we use left leg as a single lead and left arm and right arm as a single lead, and it acts as a augmented lead AVF. And the law is AVR plus AVL plus AVF is equal to 0, or we can say AVL plus AVF is equal to minus AVR. This is very useful to detect the lead misplacements. I hope it is understood why we use augmented limb leads. Coming to the precordial leads. The precordial leads are there placed over the precordium, that is the chest, and to place them we have to palpate the manubrium sternum, that is first feel the sternum arch, come below you will feel a bony prominence, that is the manubrium sternum, and see the rib attached to it. The space below its attachment is the first intercostal space, this is the second intercostal space, this is the second intercostal space, this is the third, and this is the fourth. So lead V1 will be placed in the fourth intercostal space just to the right of the sternum, and similarly the V2 will be placed in the fourth intercostal space just to the left of the sternum, and V4 is placed in the mid clavicular line, and V3 is placed between V2 and V4, and V5 is placed at the same level as V4 but in the anterior axillary line, and similarly V6 will be placed at the same level as V5 but in the mid axillary line. Whenever we record an ECG, these are the chest leads, or precordial leads, or we can say it as they detect the ECG recording in the horizontal section, and similarly we have these limb leads AVR, AVF, AVL, AVR, lead 1, V2, V3, AVF, they record the ECG in this plane section. Consider these leads as a camera. This is the lead. This is the lead 1. Consider it as a camera. How they look at the heart. This is AVL. This is lead 2, AVF, 3, 4. These lead 2, 3, and AVF, they are seeing the heart from below. That's why they are called inferior leads. Lead 2, 3, AVF, they are called inferior leads. Lead 1, this is lead 1, and lead AVL, they see the heart from the lateral sides, so we also call them as a lateral leads. And also the V5 and V6, they are also called lateral leads. Lateral leads are lead 1, AVL, lead V5 and V6. These are the lateral leads. Lead V1 and V2, they usually record the septal activity. So interventricular septal activity, we call them as septal leads. So septal leads are lead V1 and V2, and V3 V4 we call them as anterior leads. This AVR, if we see that AVR is seeing the heart in that direction, the vector is going in this direction. The depolarization vector will move in this direction, this direction, this direction, and no impulse is going towards the AVR. No electrical activity is coming towards the AVR. So we will get all deflections like P, Q, R and S. All deflections will be negative in AVR. All deflections are negative. If we find any positive deflection in AVR, we should think of either the leads are misplaced or the patient is having dextrocardia. So the precordial leads, they are placed in this horizontal plane, and this is the vertical plane. This is the horizontal plane. Lead 2, lead 3, AVF, they are inferior leads. Lead 1, AVL, V5, V6 are lateral leads. V1, V2 are septal leads. V3, V4 are anterior leads, and this is the AVR. And in AVR we get all negative deflection, that is P wave is negative, QRS is negative, T wave is negative, and if P is positive or the QRS complexes are positive or opposite as compared to other, then we should that something is wrong, and that something is either the leads are misplaced or the patient is having dextrocardia. So here we can see how that these are V1, V2 are septal leads. They are looking towards the septum. V3, V4 they are looking towards the anterior part of the heart. V5, V6 they are looking lateral part, and here we have lead 1, and this is AVL. These are lead 2, this is 3, this is AVF, and this is the direction of this is the AVR. Here if we see in this ECG, what we find is that this lead AVR, it is showing positive P wave. QRS complexes are also positive. So what should we say? I told that in normal ECG, normal ECG in AVR, the all complexes are negative, but here we find P wave is positive, R wave is there, though T wave is negative, but these two are finding. If we find the positive complexes, positive deflection in the AVR, then we have two possibilities: either leads are misplaced or the patient has dextrocardia. How will we come to know that leads are misplaced or patient has dextrocardia? Let us see. Here we see if we find positive deflection in AVR, we should think of lead misplacement dextrocardia. In dextrocardia, we will not see that R wave progression. If we compare V1, V2, V3, V4, V5, V6, here if we see them thoroughly, clearly, then we see that there is no R wave progression. If we see V3, in V3 the amplitude of R wave is less than 3 mm. So poor R wave progression is seen, or R wave progression is not seen. If we have opposite deflection in AVR, or means positive deflection in AVR, and R wave progression is not there, then why we will not see R wave progression? Because heart will be like in this direction. Leads are placed like this: V1, V2, V3, V4, V5. Vector direction of the vector is towards this. So we will all get negative deflection, means R wave progression will not be seen as it is going from V1 to V6 because the direction of the vector is opposite. So the R wave progression will not be there in dextrocardia. However, if leads are misplaced, the R wave progression will be there, though we will get a positive deflection in the AVR. I hope it's clear now. Lead reversal means left arm and right arm leads are swapped, means the lead which has to be placed on the right arm, that has been misplaced as left arm, means left arm lead is placed over the right arm lead is placed over the left arm. So whenever there is lead misplacement, we will get positive deflection in the AVR, but there will be R wave progression. R wave progression will be there as we find in normal individual, and we call it as a technical dextrocardia. Here we in lead 2 we are getting no electrical activity here. If such type of pattern we see, we call it as a pseudo asystole pattern. Pseudo asystole pattern. If we find this type of pattern in ECG, we should think of lead reversals in the lower limbs, means lower limb leads have got reversed. So technical dextrocardia means lead misplacement. The R wave positive in lead AVR, either means P wave can be positive in AVR, R wave can be positive in AVR. There will be extreme axis deviation. Extreme axis deviation I will discuss in the we will discuss about the axis in the heart. There will be reverse polarity in all normal deflection in the lead 1 and AVL. R wave progression will be there, but in dextrocardia the precardial R wave progression will be reversed or in. This is to differentiate dextrocardia from the technical dextrocardia. Technical dextrocardia is lead misplacement. Dextrocardia is when your heart is on the towards the right side, and only the difference will be there. Only difference will be that in dextrocardia, in true dextrocardia, the R wave progression will not be there. This table has a mnemonic reverse, an easy approach to remember the most frequent causes of electrocardiac artifacts. R stands for R wave is positive in lead AVR, and P wave also positive. We should think of reversal of left arm and right arm electrodes. If there is extreme axis deviation, which I will discuss, leave it here. If very low amplitude, means we get this type of as I told that pseudo electrode, we should think of reversal of the right leg, left arm, right arm electrodes. Similarly, if there is exchange amplitude of the P wave in lead 1 is greater than lead 2, then we should think of reversal of the left arm and the left leg electrodes. Similarly, if the R wave of normal progression in the precardial leads, predominant R wave in V1, predominant S wave in V6, that we should there is a reversal of the precardial electrodes V1 through V6. Suspect dextrocardia if we get negative P wave in the lead 1, negative P wave in lead 1, left arm right arm electrodes reversal. Eliminate noise and interference artifact mimicking tachycardias or STT changes. This table you can remember. If you find any abnormal finding in an ECG, you can easily make out the difference. If we are suspecting the patient is having right ventricular myocardial infarction, then the lead placement will be like this. This is same as we place in normal recording of the normal ECG, but the direction will be here we use in left side, In that case we use on left side, but for detecting RVMI we have to place lead V1R in the fourth intercostal space on the left side, V2R uh, fourth intercostal space on the right side, and similarly as we placed in that place in normal recording of the normal ECG in normal patient. This is the placement. If we suspect right ventricular myocardial infarction, we have to place the leads on the right side of the chest to record the electrical activity of the right ventricle. And these are the special placements of the leads. This over the manubrium sternum, right. This represents the right arm. Then this is the left arm. It is placed in the fifth or sixth intercostal space on the right side, and this left leg lead is placed in the lowermost intercostal space on the right side, and this form a sort of triangle, and this triangle we call as a Lewis, and it is usually uh, done to detect very small arrhythmias. This is another special technique of placing the electrodes. This represents a right arm, F1 fountain 1, fountain 3. This is placement of the left arm, left leg. This forms a triangle. It is we call it as a fountain leads. Fountain leads placement. It is usually done to detect arrhythmogenic right ventricular cardiomyopathy or dysplasia. I will repeat: arrhythmogenic right ventricular cardiomyopathy or dysplasia. Here we see epsilon waves. Epsilon waves. Two types of syndromes are associated with arrhythmogenic right ventricular cardiomyopathy. First is the Carvajal syndrome. If right ventricle is involved along with the left ventricle, means left ventricle is also involved along with the right ventricle. We call it as a Carvajal syndrome. And if on cardiac MRI, if we see fibrofatty infiltration of the right ventricle with woolly hairs with palmoplantar hyperkeratosis, this syndrome is called Naxos. Naxos. Naxos syndrome means cardiac MRI will show the fibrofatty infiltration, woolly hair, and hyperkeratotic skin of the palm or soles. Keratosis of the palms and soles. This is called Naxos syndrome. I don't think we should remember this. This was just to apprise you that we also do such type of ECGs in special situations. I tried my best to make you understand how the waveforms are produced in a normal ECG. I hope you understood. If there is any query, you can ask me by sending me the query.